My name is Mo Nikoo. I'm a second year psychiatry resident at Department of Psychiatry at UBC, of course. I'm also a PhD candidate, have been working with Addiction and Concurrent Disorders Group at Institute of Mental Health since 2014. That's been a pleasure. My co-presenter, Alireza, I've had a pleasure to work with him for the past few years. Essentially, what we will do, I will briefly go over the kind of merits of e-mental health, virtual care for substance use among adolescents, and then Alireza will touch on briefly the elements of the programs that we've been working on. So today's workshop is about virtual care in treatment of substance use for adolescents. We do not have any conflict of interest to disclose about the contents of this presentation. I would like to open about the overdose crisis that we are facing in North America, in Canada, specifically in BC. The public health crisis was announced in April 2016. Since then, we have lost more than 17,000 lives to this crisis. I have been presenting a few times over the past 2 years about this topic. Every time I've been like, like the number of fatalities are a little bit less. It's a little bit more. But the bottom line, it's always been like it's unacceptable how many lives we are losing to this crisis. Pretty much in BC, which has been hit the hardest by this overdose crisis, we have been losing 4 lives every day to overdose, which is very sad. What have we been doing? We have to acknowledge that there have been a lot of initiatives in an attempt to tackle this crisis. I put like a long list of federal actions and opioids. There have been a long list of like provincial actions. In the realm of harm reduction, we have had increasing number of safe consumption facilities, drug testing, wide distribution of naloxone kits. In the realm of treatments, we've had like approval of injectable opioid-assisted treatment, much relaxation in terms of licensing for methadone. We have slow-release oral morphine KDN as one of the treatment options approved for opioid agonist treatment. In realm of prevention, we have had a lot of initiatives targeting like at-risk populations, youth, First Nations, and in terms of enforcement, there have been also a lot of efforts like trying to prevent importation of fentanyl-laced substances, although it's kind of difficult because now I believe we have like a production of fentanyl inside Canada. So we have to acknowledge all these initiatives. However, the next question is that have they been enough? In my opinion, and I hope everyone would agree with me, given the number of fatalities that we have been observing, especially COVID hasn't been helping with that, we need to do more. So thinking about all these initiatives, one may wonder, like, what are the challenges? And I think it takes me back to this quote from Albert Einstein. We may need to change the way we think about this crisis and the way we are doing our business. We need a change in our strategies and the way we are thinking about creating or putting together all those strategies. We do have challenges. So I think one place to start in terms of what we can do differently is that, like, really, what are the challenges for effectively treating substance use disorder in general? One is the treatment capacity we have. This graph is from 2016 UNODC report. It's global, and from every 6 people who needed who had substance use disorder, only 1 accessed treatment. This has been updated in 2020 report, and out of every 7 people now, 1 can access treatment. I would like to highlight that this is access to any sort of treatment. If we raise the bar, looking at the minimally adequate treatment, the percentages and proportions are much lower. Also, these numbers are subject to huge disparity, inequality. And when we look at the low resource setting, the number can go down even to like 5, 6, 7% of people with substance use disorder access treatment. One of the ways that I think about virtual care is that we do need to make a lot of investments in startups and creating the solutions. However, when we have good, effective solutions, the cost related to maintenance of those solutions is quite low. So if we remove the duplications in terms of creation of the solutions, startup, we can increase our treatment capacity with having lots of effective solutions, low maintenance cost. The other challenge that we are facing in complexity of substance use disorder, and I believe like all health conditions are quite complex to treat. It's not about medications only or psychological interventions only.
Oh, there is one question that are these figures for youth or is it for general population?
No, it's for general population. Yeah, thanks for bringing it up. I could have
if not for youth, do you have any idea about youth figures?
That's a really good question. I would be surprised if they are much higher. I believe, for instance, I can think of like in BC, we do have certain initiatives like Foundry, and they have been tailored to youth who need treatment with substance use disorder. They often they have extra services, but I still do believe that the treatment capacity for youth still falls way short of the capacity which needs to be there. We do have, even like in my clinical work, I do see a lot of people who still have difficulties with accessing the treatment. However, I don't have the exact numbers off the top of my head. What's the challenge or what's the numbers for youth? If I would look it up, I will share the numbers with the group. Thanks. That was a great question. So the next challenge is complexity of substance use disorder treatment. And when we look at substance use disorder in general, it definitely covers all the areas of biological, psychological. We do know that among patients with substance use disorder, we have a very high rate of psychiatric comorbidities. There's often a very complex social situation in terms of employment, in terms of housing stability, and often there are even like political elements which play into treatment for substance use, cultural factors, and so on and so forth. I do believe that the virtual solutions can increase the diversity of complexity of strategies for treatment of substance use disorder in general. And they have these options for transferability, cultural adaptation. It just makes it easier compared to physical in-person sort of treatments. The next challenge that we have is timing. So we know that substance use disorder starts in the second decade of life, around like average 25, 26. Usually it takes a decade until patients develop the full-blown severe forms of disorder at risk of overdose. So this is a huge opportunity. then patients who have this condition, it takes them a while until they have their first overdose. And then we also do know that in many cases, the first overdose is not the fatal overdose. So we still have time from first overdose until fatal overdose. The first overdose, in my opinion, is a huge alarm for care providers that these patients at very elevated risks of overdose. Virtual solutions appeal to the younger generation, so that will so these solutions can help us intervene early enough to prevent disastrous outcomes that we are seeing today. And the next challenge is provision of psychological interventions. As I mentioned, we have like very high rates of psychiatric comorbidities. In severe cases, we have numbers up to 70%, 70 to 90% of patients. Usually provision of these psychosocial interventions can be quite difficult because they are resource intensive. And we know that we do have a lot of good virtual psychological solutions for like targeting comorbidities like depression, anxiety. And I believe we can blend them into the overall continuum of care for substance use disorder. And as I mentioned, the maintenance of these solutions are quite low in terms of cost and resources. So I think what I've been trying to do briefly in these slides is that to just make the case that e-mental health can be a powerful tool combined into the continuum of care for substance use disorder. And don't get me wrong, I'm not professing that e-mental health is the solution or is the golden bullet or is the holy grail in dealing with this crisis. I think maybe that's actually part of the problem, that we do tend to think that, you know, this is what we need to do. This is the only one solution sometimes. But I don't think that's the case. But the case I'm trying to make is that e-mental health is an important tool which can be incorporated into the continuum of care, and it can increase the treatment capacity, increase the complexity, sophistication of our treatment strategy, help with provision of psychological interventions, helping with improving the quality of life. And that's pretty much the case. Now I will let Alireza take it away and introduce the solutions that our team has been working for the past few years.
Thank you very much, Mo. So hi everyone. As Mo also mentioned, my name is Alireza and I am a medical graduate with background in software engineering and PhD in health informatics, working as a researcher and data scientist with addiction and concurrent disorder in the last 6 years. So today I will present some highlights about implementation and engagement strategies that we used in 2 e-mental health platforms. One is Walkalong, which is a publicly available website and publicly available on walkalong.ca. And the other one is Ramp, which is in beta version and is available for a limited number of users via the password protected site ramp2walkalong.ca. But before we go into the details of each software, I want to talk about a common strategy. So no matter how good is your software, you need to promote the platform to increase visibility and attract users to work with it. And so several strategies can be used here to promote your services and platform. One of the proven strategies is to promote your platform through social media. Facebook, Twitter, Instagram, Pinterest, and Tumblr are examples of social media that we used in Walkalong and Ramp to increase visibility. Organizing and participating in the events is another strategy that includes hackathons and exhibitions in addition to conferences. Visibility among search engines and specifically in a specific Google is an important promoting strategy. Improving the rank of the website when people are searching for similar services can increase the visibility. In order to achieve this goal, we need to use search engine optimization methods, something that we call SEOs. We have to use relevant keywords, proper indexing for Google, and also proper and also linking your page to relevant external links, and will really help to increase your visibility. Something that we have done here, and you can see that we have backlink to the other website, and they do the same thing. So this will increase the visibility pretty much. Using champions and finding advocate is one of the more important strategy. It is especially important to design the system with the users, something that we call user-centered design, and something that we call user-centered design, and design with them, something we call it as co-design and co-development, and promote it by them. Especially people with lived experiences are of high value in this process. Collaboration with national and international organizations will increase the credibility of the job. Also, better funding and partnering with international groups will allow you to hire better companies and more professionals to develop a better software. Also, telecommunication companies are important sources and should not be undermined. For example, in Canada, Bell and other ICT companies are funding development of applications in this area. And for example, we use Bell Let's Talk grant as one of the resources to develop walk-along. And now I'm going to talk about some walk-along features and engagement strategies in more detail. So walk-along is a web portal and web application mostly geared toward youth mental health with focus on depression and anxiety. The welcome page mostly focuses on different functionalities that are available on the site. And it is important, it's really important to educate the user, the first-time user, about the scope and features of your site. Let them see what features are available through your application, and this is the reason that without registration we allow them to explore the system. And since the COVID-19, we have added a few tips about the pandemic here. And to access most of the information and education components of the software, you don't need to really register. This is particularly important because it allows the visitors of the site to have enough time to explore different sections and get engaged. One of the problems with many mental health websites and apps is more than 75% of the visitors are leaving the software without even starting to interact with that. One of the important drivers of that is to have mandatory registration policy to view any content of the site. So we really shouldn't oblige people to register before they can see what's the content, because it takes time for people to really build trust. And one of the information education component that—
Right where you were touching it back, lower down.
Sorry, I said, I think it was somebody just unmuted. So one of the information education component that you can explore without registration is encyclopedia, which will provide reliable information on different subjects. Or a newsroom, you can get information posted by the site administrators. And also you can filter the content that is posted here by the topic. The platform allows anonymous registration, which is shown in the previous investigations and studies. That is an important factor for youth to start exploring different features of the site with peace of mind. And in walk-along registration will give the ability to unlock some new features. So this is another engagement strategy that are also used in the game industry to attract users to stay and explore the platform. And also we use it out of the game environment and in blog entertainment, out of that entertainment environment, something that we call them as gamification strategies. And so now I will present some features that are available when you register. So walk-along assessment includes PHQ-9 and GAT-7. The first-time user will receive both assessments, and then the system will suggest such an assessment based on the need. And upon completion of an assessment, the system will provide you scores and some suggestion on what to do and not to do, and some resources for further read. Another feature is experiences. So you don't need to actually register to read things, but when you want to post something and you want to share your experiences, you can do it upon registration. And Locker is your own private place to post your thoughts, images, videos, and tools that help you cope. You can share them with others on the hallway or keep them private for yourself. So self-help experiences are different exercises. This is another important feature. They are different exercises and interventions designed to help you better cope with your mental health problems. These interventions include different CBT techniques, things like here you see realistic thinking, calm breathing, etc., etc. These features provide you with a short description of the exercise, possible evidences, multimedia, and much more, so that you can self-learn the technique. Using Life Chart, you can register your mood, sleep, alcohol, and substance use, and social and physical activities as frequently as you wish. You can also write a journal diary. Then using this interactive life chart graph, you will be able to visually monitor all those information and your assessment result in one graph over different periods of time. So you can show or hide any of the results to be able to compare them in an effective way. And not putting too many items on the screen so that it becomes messy, but still being able to compare a handful number of subjects simultaneously. Now let's talk a little bit about RAMP features and strategies. So RAMP, or Risk Assessment and Management Platform, is another web application currently under development. The current beta version is password protected and available to a limited number of users. It is designed to work on both mobile and desktop platforms. The aim of RAMP is to make people at risk aware of their risk factors and empowers them to manage these risks. The current version mostly focuses on substance use and risk of overdose, but will encompass several other domains such as self-harm or trauma in the future. Even the current version includes several features such as assessment, educational modules, goal setting, symptom diary, and tracking symptoms, and many more. RAM currently offers 3 assessment tools, and among them, high-risk assessment is the base for all other suggestions and interventions. So several risk domains are covered through the HRA questions, and upon the completion of HRA, modules, goals, and other assessments are suggested based on the HRA results. We have developed several educational modules. This is content development, and some of them are more specific towards substance use, and some of them are more general. And each module has a few lessons. Lessons are designed as questions and answers to better engage the user. It may also contain video or multimedia or animation as an engagement strategy. And the platform allows you to set 1 or 2 goals. And under the goals, we have some tasks and activities. Then the system will monitor your progress on both task and goal levels. You can revisit your goals and tasks if they are too difficult to achieve or too easy to give you enough challenge. The system will provide reminders and achievement reports on a regular basis. This is important to keep the active users continuing with the system and encourage inactive ones to interact with the system. And although we all know that it is important not to overwhelm the user, we try not to do it very frequently, probably every 2 weeks or every week. This is an email is going to them. And also, we have navigation of healthcare, which allows the user to navigate through healthcare resources. Via this component, you can access addiction centers and centers who are providing youth services and general mental health clinics. You can easily find centers that are near you with their information. If they provide online appointment services, you would be able to access them. So this is actually a geographical information system kind of approach where different type of services are layered and you can hide them or make them visible in order to focus on your desired services. This component strategically helps who are in need to have better knowledge about the kind of services around them and seek them. So we are currently adopting Input Health Visual Care solution to our visual substitution clinic module. So Input Health is an agile software development company with many innovative ideas. They are currently working with us to build GRAM. So virtual care functionality includes both synchronous method like video and voice chat and asynchronous method like text chat and email to engage and reach out to patients. Thank you very much. And now we will have question and answer and open discussion. We would really love to hear from you, and if you give this opportunity to us to hear from you and see your feedbacks by unmuting yourself. And we have also posted some ideas, but you're more than welcome to bring in your own ideas and ask questions. Thank you very much. So some of the questions that we posted are shown here. And it's also available in the chat.
All right, folks. I see representatives of Foundry among our participants who introduced themselves. They've wonderful services for use. Do you have any specific questions, Elias, or what are your thoughts about the overall concept we introduced?
Well, one thing I really appreciate the kind of context and the questions you guys posed to like not wanting to reinforce some of these structural barriers. And I didn't know if you had any suggestions for, that's one of the things that we have experienced is that, especially with communities that have low connectivity, that just the challenges with remote access in those ways, and telephone, especially for young people, that was our biggest lesson learned, was that, I don't know why, but I was like, the idea of picking up a phone and calling somebody is not something that my generation grew up with, but the next generation has, well, probably 2 generations far, hasn't. Like, that's just not something they're comfortable with. And so I don't know if you have any suggestions for that population, or for kind of increased connectivity in communities that don't have easy internet access or other things like that. Sorry, I don't have an answer. I had a question for you.
Oh no, wonderful. Thanks for asking. That's a great question. I think off the top of my head, some thoughts that I wanted to share. I do acknowledge that's a barrier, and it's not only about the younger generations. Like, different age groups have their own challenges with accessing services, like virtual care in general, and I think I've been impressed with with the efforts that our healthcare providers have put into this and trying to work their way around these challenges. As I mentioned about the complexity of services that we can provide when we have these online solutions available. For instance, one advantage for virtual care in terms of assessment, we do have a lot of evidence that people actually may feel even more comfortable disclosing their substance use information. In terms of working with patients, absolutely, there are people who really need face-to-face interventions, even physical presence. I think, but there are some other patients, and I've heard it from my psychotherapy supervisors, that sometimes people are actually even kind of very anxious to be physically present in the interview. And I think that's maybe kind of touching on the complexity of the strategies that we have. So we have patients who obviously benefit more from a physical face-to-face interventions, but there might be also some of our some of the people that we are working with that they benefit more. You probably more than me, who may benefit actually from virtual care. That's actually. Or maybe in some other way we can think of it as a stepped care. Maybe we can start if the readiness to engage with treatment is lower, maybe online solutions can be an option. I don't know. I just shared my thoughts. So I hope there were some answers to your wonderful question.
I think also that probably there are a range of tools for a range of needs. So basically, not one one tool would fit every need. And I'll also think that, for example, some people that are good with the telephone calls or that, let them do that. So if there are people that they want synchronous kind of interaction with their care provider, let them go for that. If they prefer asynchronous, like text messages, emailing things, they want to be anonymous. So I think different kind of options we have to provide so that we have it better.
Thanks, Alex, for the question.
Thank you very much. Thank you. So can you ask one more time, please?
Sorry about that, of course. So the question is that, would it be possible to think about a way for professionals to have a special access, I believe, to those websites and solutions that we introduced, so that they can introduce their clients to use those platforms?
Yeah, I was thinking that probably one component that it's really, it needs thought, and it's much more than just a system or a website is the peer support. So the peer support allows peers to access and help the people who are in need, and also interact with them. That can be professional, that can be friends and families, but we need to really think about the different dimensions. Also, the virtual care solutions, mostly they allow, as I mentioned, like both synchronous and asynchronous collaboration with the users, so that, for example, they can start a video chat, they can start an audio chat, or they can use text message on those platforms, so that they can talk to their care provider or even a nurse or any even peers that they have, so that they can talk on that kind of platform in a secure way. Because also I think that the ethical concerns are very important, and we have to really think about the privacy and confidentiality and all those things.
Thanks, Alireza. I would like to add a few points. Did it answer your questions? I was wondering, I was trying to understand your question, Karina, and you may actually kind of clarify if it's needed. So I felt that you were also wondering if we could provide professionals with some sort of access to these platforms, so they can have their own interface, and then clients have their own interface. Is that what it is? or you can just put it in the chat box. So I think what I wanted to add is that, like, from the very beginning, we were very well aware that we need plenty of support from people who are like working with the patients for successful implementations. I think one of the questions that we had among our questions is that we do have a lot of products that there's a lot of investment going to them. They've been created, they're good products, but they actually end up not being used so much. And I believe, like, Alireza touched on one very important point, and that was essentially involving the users from early on in the process of creation and implementation. We also think that a key group, a key population that we need their support with for successful implementation of these products is health, like in general, care providers, and what we have lined out in terms of planning, we have a phased implementation strategy after we have the solutions ready enough to be implemented. And then we will engage stakeholders, care providers. They will have their own interfaces to these platforms, and then they will support us for a wider implementation. At this point, we had a discussion. They are not ready. Walk Along is publicly available. For RAMP, we have been thinking about, like, the professionals interface. It's not ready yet for that type of access, but for sure we have been thinking, and we are thinking about that. Does that answer your question, Karina? All right, we have another question coming through the chat from Katrina Ludwig. I work with mandated use, and I have found that using virtual has been a great experience for youth, as they're able to save face and more likely to do productive work. They're able to distance themselves a bit. It also takes the stigma away. Yeah, those are really wonderful points, Katrina, you've made. Thanks for sharing your experience about working with youth.
So do you think, based on if you can also unmute yourself and talk about it, or you just put it on chat, it's up to you. But what do you think? Do you think mostly like the synchronous ways are better, like when they open, they start for video chats and things like this? Or is it like when they text anonymously or even with registration or whatever? What do you think are the synchronous more attractive or asynchronous, or how they work in your work area?
Were you asking me? This is Katrina.
Yes, Katrina.
Yeah.
Thank you very much.
Yeah, I find with my youth, and again, my youth cover a wide spectrum, many of which are also have various concurrent disorders, or they may suffer from cognitive disorders, that they're able to express themselves better in the virtual platform than they are in a face-to-face. It seems to take that level of intensity down a notch for them, especially with some of the youth who have something like ADHD. You're able to build a connection quicker, and I don't know why, but they just seem to trust this platform. Maybe it's because the youngers are, that's how they communicate day to day, but they have a level of comfort with this platform than when you're person to person. They also, being they're mandated, it takes away that stigma that they're criminals, or that we're working in conjunction with the justice system. There's a level of privacy that they're more comfortable with in the virtual world. At least that's my experience.
Yeah, and they mostly use kind of text chat or they prefer to really have video chats or kind of what are their preferences mostly?
That's a really good question. They tend to prefer texting or virtual, but I find texting they have more access to than some of the virtual platforms. As a government source, we're only able to use Skype. And so I don't know if that's not what young people use or how it is, but they tend to like the Skype, the texting. Again, it builds up that buffer, I think. Also, I'm in the north, so we happen to have youth in quite a wide spectrum of areas, many of which may not have the same connectivity. So it's easier also for them to use the texting format.
Perfect. Very, 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 very informative. That was really, really, really nice. So yes, probably this is something that we have to always think, and that's what I was also trying to really understand myself and really explain that really there are a range of tools needed, and probably different people have different needs, and especially individuals with special needs are they need probably some sort of platform specific to their own need, and that's something that it has to be. Probably Skype provides some kind of functionalities, but maybe a research can be done in this area and to see that if there are specific platform created for individuals with special needs, if they help them better.
Yeah, they can also, a lot of my youth who have trouble with writing, they speak into their phone and it transcribes it for them, which also helps them communicate in a way that maybe they wouldn't be able to in a face-to-face environment.
Yes.
Thanks, Thanks, Katrina, for sharing. That's wonderful experience, and it keeps me thinking that it's just one additional tool, as Alireza mentioned, in terms of diversifying the tools that we have, just making us prepared to cater our services in a better way to the needs of the populations that we are serving. And it's wonderful, different intensity of interactions. I feel like text messages, and we are making a lot of progress in transcribing, and then we have video chatting, and then face-to-face, which is also, I believe, a core element of the continuum of care. And that just helps us engage better with the populations we're serving, especially people with special needs, like the population that you are working with.
That's wonderful, yes. Thank you very much.
We have a question coming in from Mike. From my experience, asynchronous is accepted best in many situations across time, but that the availability of synchronous contact once accepted can be very productive.
That is interesting. That is very, very, yeah. I can see that's also something that I believe in. I think that, as I mentioned, probably takes a little bit of time, especially for the case that was mentioned and Katrina mentioned. So basically, individuals with special needs, it will take more time that they trust you, they start interacting with you. But when they trusted you and they started interacting with you, other kind of technologies, for example, synchronous technologies can be a good fit for them to provide services for them. Or probably in future, there will be much more provided, for example, point of care systems or wearable devices or other things can probably be used more. specifically during the pandemic, we have learned that this kind of online solution and virtual solutions are really a good fit, and range of them will help people.
And I would like to add this point. I feel, you know, to my understanding, I don't feel there's a sort of some sort of competition there. It's really like we are falling way short of the needs of population, youth who are at risk of overdose, who are dealing with substance use, and just having that range of treatments. It just increases our capacity, increases the complexity of services that we are offering. And absolutely, I think how Mike mentioned in the chat box, like there are like different options when the face-to-face work. Of course, when it doesn't work or we don't have sometimes the capacity for it, we can use these asynchronous methods to just increase our treatment capacity, engage our people whom we are serving, and then like having a stepped approach for engagement of these people. Yeah. Ellis Durant. This important discussion around synchronous versus asynchronous is helpful to keep in mind. WRT, rural and remote connectivity topics too. Thank you.
Thank you. But can you unmute yourself or give us more explanation of that? About the rural area. Yes, thank you.
Yeah. I just wanted to, I think that idea, the question I had around connectivity and challenges that we have with communities that don't have easy or accessible or safe internet access, like let's say it's at their school or it's at a library, like, well, there's wherever they get it, whether it's A&W, for them to be able to kind of come and have this asynchronous care relationship, I think is actually maybe more acceptable, may make them feel like this is kind of care on their own terms, but also is another important option to provide with young people in that way. So thank you for.
Thanks, Ellie. Sorry, I think missed that part of your first question. And yeah, absolutely. That's another challenge, like the connectivity, having safe connections is a challenge, especially in rural areas, and they're quite underserved. Even in a country with high GDP, Canada, we do have a lot of shortcomings for serving them, and connectivity is a big challenge. Thanks for making that point.